Good afternoon. I'm Dr. John Davison, CEO of the Trust, and I'm glad that you're able to join us today for the sixth webinar in our Business of Practice webinar series titled Demystifying the Mental Health Billing Process, Legal and Ethical Financial Practices. Presenting today's webinar is Dr. Crystal Stanley, a clinical psychologist, successful group private practice owner, and adjunct professor. She earned her PhD in counseling psychology from Penn State University and has been practicing in the DC metro area since 2009. Dr. Stanley is the founder and director of Renew Psychological Services, a prominent group mental health private practice. Since its founding in 2010, the practice has grown and currently includes 15 clinicians who serve the DC metro area and states where PsyPact has been enacted. The practice also supports doctoral training, offering 6 externship positions each year. With a diverse team of licensed psychologists, LPCs, LGPCs, psychology associates, and pre-licensed trainees, Renew has built a reputation for high-quality, culturally responsive care. The practice has a strong commitment to training, serving as a clinical site for doctoral externs and early career professionals, and offering structured supervision and mentorship across all levels of licensure. In addition to being a business owner, Dr. Stanley provides clinical direction and supervises clinicians across state licensure and training stages. She also serves as a director on our Trust Risk Management Services Board, and we greatly benefit from her professional leadership and business acumen. I hope everyone learns a lot over the next hour. Please join me in welcoming Dr. Crystal Stanley.
Thank you. Hi, everyone. I'm excited to be here to share with you what I know from practice and experience about billing. Um, in terms of my credentials, if you will, I started a solo practice in 2010, right after I got licensed. And I got myself on insurance panels, I think starting in about January of 2011. And then my practice transitioned from a solo practice to a group in 2012. And throughout that time, I did all of my own billing. So a lot of what I learned was trial and error and trial by fire, really. And also, it was a different time back then because I did a lot of my billing on paper. I didn't get an electronic health record, I don't think, until 2012. So if you have an EHR, you're way ahead. There are a lot of things I had to deal with that you will not have to deal with. And some of the things we'll talk about today in terms of billing have been enacted thanks to the Affordable Care Act. So when I started in private practice, most people had session limits for the year. So it could be as low as 20 sessions or maybe close to a year's coverage of sessions. And for some plans, you had to recertify. So for most commercial plans, at least, that's not the case these days. I know there are some commercial insurers that are that way, but that's been a huge advantage to our field, where mental health services were covered in the same manner as medical services. So those are just some changes, and I'll reference that along the way because it has an impact on how we're able to treat folks. Um, so the billing process can often feel overwhelming to folks. And that's understandable, especially as you're trying to wrap your mind around it and just understand the basics, which we'll talk about today. But the reality is it's not actually very difficult once you get the hang of it. The most time consuming involves maybe a little bit on the front end checking the benefits, although many insurers have a website where you can check that people's benefits ahead of time. And then on the back end, doing reconciliation, which we'll talk about in a little bit, can take some time just to make sure that you're getting paid what you're supposed to. And then, of course, the most time consuming is if there's a problem and you're trying to figure out why. So obviously, everything that we're talking about here today, these are general guidelines, no guarantees. But the hope is that it will minimize those times when you have to get on the phone and call the insurance company and figure out what's going on. Although those can sometimes be inevitable. For things on the back end with the insurance company. And so, like I said, what we're talking about today are just general guidelines For more in-depth questions, you'll certainly want to defer, or I will defer to your insurance company, and also know that each insurance company operates very differently. So just some general disclaimers and just to let you know where I'm coming from today. So for the agenda, this is what we'll be covering today. Why is this topic important and why is it an important risk management topic, which we'll talk about first. We'll walk through the billing codes. Just as a note, I'm going to be talking about general psychotherapy codes, and I will talk about testing codes, but I'm not going to go into codes for example, if you have an IOP or an extensive, some sort of outpatient treatment clinic. That billing is probably a little bit more complicated and probably has different rules than what we're going to be talking about today. So that's just a note. I'm sorry if you were hoping to hear about that, but like I said, for most folks, you're doing basic psychotherapy codes and or testing codes. We'll talk about generally understanding insurance reimbursement, and I'll talk about this from the standpoint of someone who's credentialed with an insurance company versus someone who's out of network. Because I think I've probably said this before in other seminars. I do think it's important, whether you're in network or not, to sort of understand how insurance works for reasons I'll discuss on the next slide as we're thinking about relationships with clients. And then we'll talk about billing policies and documentation that are going to be important for your practice, which are also good for risk management. So keeping that in mind. So why is this important? I always, and as I'm thinking about risk management, I always think about, of course, the relationship we have with clients, right? And I think that a lot can be, let's say, diffused if you have clarity in your communication with your clients. If you're upfront with them about the process, um, you know, what is billing, and I'll talk more about this as we get into documentation. But, we're in a relationship of trust with them. They are expecting us to be clear about what we're doing, how we're billing, what they owe. I mean, of course, folks really want to know that up front, and that's part of our imperative is to deliver that information to them, to let them know this is your response, these are your responsibilities. With insurance billing, you would want to talk with them about what happens if it doesn't get covered, how soon you'll let them know. And so again, they want to know and feel comfortable with the relationship that they've entered with you. And particularly because of the nature of the work that we do, we're having these, intimate relationships with folks that people have never had before. Intimate in terms of they're sharing things with us that they haven't shared with other people. They're trusting that we're going to help them. And our services do come with a cost. And so it's important that people, understand what they're coming in for and what their financial responsibilities are. I think that we as clinicians, and I know people may feel differently about this, I think it's good practice to confirm the benefits ahead of time and or let people know that you're not going to. So whatever you decide to do, you are clear with clients at the beginning about your relationship to their financial billing process, especially if you're billing directly to the insurance company and if you're out of network and they're responsible for sending in a bill. So that's going to be important. And I'll talk a little bit more about that when we talk about insurance reimbursement. And if you've ever worked with insurance at all, you understand that the process is not an exact science. And for me, I always like to let clients know that at the beginning, right? This is what I'm going to do. I'm going to send your bills in or your claims into the insurance company, but the insurance has the final say. So even if I call or check um, and let people know, or call and check and find out what your copay is or what your deductible, that sort of information, even though I confirm that, I won't know for sure until I send the claim in. So I let people know that up front, and I will let them know that I will let them know as soon as possible if I find out that there's a discrepancy. And what we're trying to prevent is people, not likely, preventing people having a large bill. So, they thought that they had a $15 copay. Turns out they have a deductible. Now they owe you hundreds of dollars that maybe they don't have or they did not agree to pay. It disrupts the service. And so we're trying to minimize that. And certainly that can happen with the best process, right? Like you've done dot all your I's, crossed your T's, check the benefits. That can still happen, but it's typically rare for that to happen. So just a note there. And again, these are things I like to disclose to clients at the beginning. It's part of my agreement with them. So, in terms of ethical practice in our processes, we're going to be discussing billing rules because there are rules about a variety of things related to billing codes. So, we'll talk about that. And so, overall, you'll want to make sure that you're billing for the proper service type, which we'll talk about, and that you're not fudging your billing. Um, yeah, I mean, I think as we're thinking about risk management, people can sometimes make errors, if you will, due to anxieties about money, right? As a clinician, especially one in private practice, things can feel very dicey sometimes, or there's a lot of anxiety, of course, which is reasonable about our own stability, which we'll talk about in a moment. But there are rules that we are expected to abide by, which I will talk about with billing. One thing I will say, if this makes you feel anxious, is that you can always send in a corrected claim. So if you find that you sent in a claim, maybe it was for the wrong amount of time or the wrong CPT code, you can send in a corrected claim and the insurance company will be reprocess it. So you always have the possibility of like correcting any errors you make. So that's a note. You don't have to be afraid that you've only got one shot to get it right. You can make corrections. And then the final piece is for business stability. So related to ethical practice and, not being in a position to fudge I mean, you should never, but, for people who might fudge their billing, you know, in private practice, we're very concerned about making money for, if nothing more, just to pay our own bills, right? And so it is important that you understand how your billing impacts what you're reimbursed, so that you have a better sense of, okay, if I'm billing this number of CPT codes each week, how much might I expect to make? That's useful, obviously, as a private practice owner. So, what are billing codes? So, these are managed by the Centers for Medicaid and Medicare. And CPT stands for current procedural terminology. So, basically, it's what service are you providing? And there are CPT codes for medical services, across the board. CMS manages all of that. And so, just at a baseline level, what type of service are you providing? So, we'll take a look at common psychotherapy codes in just a moment. Um, the code indicates or has allowances for a certain number of units, which we'll talk about as we're looking at billing codes as well. So, that's sort of cooked in how many units are allowed each week, if you will, which I'll talk about. Um, but also, the CPT code includes information about how long a service should be, um, how much the insurance will reimburse for that service, because there is a difference between lengths of time for certain codes, and then what is eligible for coverage. So, um, you'll want to confirm part of your confirmation as you're calling insurance companies is to understand, are there codes that are covered or not? And on the next slide, when we look at common psychotherapy code, I will talk about ones that are generally covered and others that you just want to confirm with your insurance company. So your CPT code includes, sort of a shorthand, but it includes a lot of information for the for the insurance company, and they will process your claim accordingly and reimburse you accordingly. So, thinking about outpatient psychotherapy with a client, these are the basic codes. So a 90791 is an intake. I've got time rules here on the side, which I'll talk about in a minute, but a note is that 90791 is the first session that you bill for a new client. It's your intake session. It does not have any time rules. So I guess that session could be 30 minutes, it could be an hour, it could be 2 hours. You'll be reimbursed the same amount of money for that code when you use it. I've heard some people wonder at times, in your practice, you might think, the first 2 sessions are an intake. I would check with your insurance company. I don't know. I've never billed for two 90791s personally. You would want to check to see if your insurance company would cover two, if that's a typical part of your practice to have maybe two sessions at the beginning that are more extended for your intake. Also, that is the intake code for a variety of therapy types. So we see the next 3 codes are for psychotherapy, 30 minutes, 45 minutes, or 60 minutes. And there are time rules for that. And that is a change that happened, I think, around, I can't remember, maybe 2013 or so, where prior to the change, there was a code for a 90-minute session, but as you see here, it doesn't exist anymore. So if you're gonna bill for a 30-minute session, your session needs to be at least 16 minutes and can be as long as 32 minutes. If your session goes beyond 32 minutes up to 52 minutes, you would bill for a 45-minute session. And then anything 53 minutes or beyond would be considered a 60-minute session. So if you've got a question about, okay, I'm meeting with a client and we met for 90 minutes instead of, what's the code for that? It would be a 90837. I'm not sure. I know in listening to looking at listservs and such, there have been questions about whether insurance companies are comfortable covering a 90837. All the insurers that I work for do cover that extended session. You would want to check. I know there were some, I obviously will not say which companies I've heard do not, but there are some that cover it, but kind of give you a hard time about it and might ask for a clinical review every few sessions or every several sessions. So I would just check with your insurer about that. So that's a note. And then, of course, for each of these first 4 psychotherapy codes, insurance companies have a fixed amount that they reimburse for those codes. And so, as you might imagine, I mean, the 90791 typically pays the most. And then 832, 834, and 837 are reimbursed at rates that are different. So a 90837 would be more than an 834, more than an 832. Probably makes sense, but just a note for that. If you credential with an insurance company directly, they will send you, as you're in your credentialing process, probably towards the end, they will send you a list of all the codes that are allowed, although I still would check with some of the codes that we'll talk about here, and what the reimbursement is. And we'll talk about reimbursement in a little bit. There is a code for psychoanalysis. And then for family psychotherapy, there are 2 codes, without the patient and with the patient. 50 minutes is the time rule, and you have to meet for at least 26 minutes. And then for group psychotherapy, that's another code that does not have a time rule. So whether you meet with a group for 30 minutes or 2 hours, the reimbursement is the same. So that is a note. Okay. For each of these codes, you report them in units. So it would be 90791. If you use an electronic health record, which I imagine most people do at this time, it would default to 1 unit. So that is a note. I have not heard of, this just came to mind, I have not heard of people trying to submit a code for like a 90832 times 2. You would just do the 30 minutes in case you're, wondering about that. So there are also billing codes for psychological testing and neuropsychological testing. A couple notes here. Looking at the first one, just as an example, there is, first, in terms of the descriptor, you'll see that there are different codes for different types of assessment. So the neurobehavioral status exam, including face-to-face time with the patient and interpreting results and report preparation. All of that is included in these codes. So the 96116 is your first hour of work on that process, including all of the things listed there. And then each additional hour is billed as a 96121. So if you were um, submitting this through electronic health records, you would bill at least one 96116. You can only bill one. And then each additional hour. So if your report, administration and report writing and all of that, sharing and results with patients, if that took you a total of 12 hours, then you would bill one 96116 and 11 96121. However, the thing that is going to be important as it relates to assessment is you do have to find out from your insurance company how many total hours they allow for the assessment process. So it could be that it took you and your team 20 hours between administering an exam or various assessments, interpreting results, writing reports, providing feedback to clients. It is also possible that the insurance company says, well, that's fine, but we only reimburse for 12 hours. You would only get paid for the 12 hours. And that's if you're in network. As an out of network provider, you would send a super bill to your client with all of the billing and the time, how many units of each you used, and the insurance company would reimburse them in whatever way on the back end that they do, but it still would only be the 12 hours total, if that makes sense. Um, Let me see if I have any other notes. I'll leave some time for questions, but I have this here for your reference. So as we're looking at the chart, you want to take a look at the CPT code, what that covers in the descriptor. And then looking at some of the other codes, so the 96138 and the 96139, the first code only covers the first 30 minutes, and then it's billed in 30-minute increments. So that is something you would want to be aware of as you're doing testing. And like I said, for your own process, especially as an in-network provider, you want to make sure ahead of time or understand ahead of time how many units total are covered, how much time that includes, so that you are making allowances in your assessment process. So I think, yeah, I'll leave some time if there are questions about that. But again, um, descriptor of the work that you're doing, total number of units, and how do you count the unit? Is it an hour or half an hour? Um, I mentioned before that one of the benefits of the Affordable Care Act, one of the changes that happened that was really beneficial for um, providers is that generally there was a removal of session limits. So I mentioned before, back in the day, I would meet with a new person, I would be confirming their benefits, and they only had 20 sessions that the insurance company would cover. Or it would be a chunk of 20 sessions. Then I'd have to fill out a form, say why treatment was medically necessary. Um, by the time I got into practice, the insurance company generally would cover it, but it was never a guarantee. So that might lead to disruptions, which was, stressful for folks. In my experience, that is not the case anymore. Um, and there are now people can be seen for many insurance companies multiple times a week, which was also an issue back in the day. Imagine if you only had 20 sessions, you could only be seen once a week. But what if you had a crisis? That would count. I mean, first of all, the insurance company wouldn't cover it. And so people had to pay out of pocket for one of the sessions a week. That is not the case anymore. Typically, it's one session per day for psychotherapy, individual psychotherapy, um, multiple times a week. So that's a note. Yeah, and it's generally one time a day for individual psychotherapy. My understanding is if it's a different treatment type, so individual psychotherapy, it may be a family session or a couple session. That is a note. I forgot to mention this. I'm going to talk about the psychotherapy codes again. You want to check with your insurance company about whether they cover family sessions or couples therapy sessions. So some insurance companies do not cover couples therapy. I don't know why. So that's a code that's not billable and reimbursable. So for some insurance companies, so you want to check with your insurance before that. I forgot to mention too that the individual psychotherapy codes allow for a client to bring a person into session. So again, it's not family therapy, not for couples therapy. But if the client that you're seeing, when I was in grad school, we called it having a consultant, if you will, a clinical consultant or like a family member or something to talk with during session, that is allowed in the individual psychotherapy codes. But like I said, it's not um, you would talk to your insurance company about this, but it's typically not, those are not eligible for seeing couples. So that's just a note. So with your coding for insurance, this is something that you can let clients know in their informed consent. The information that you're sending to the insurance company is the date or dates of service. So if you've seen somebody multiple times a week, you would include those dates. The location code, if you're meeting with people in an office, the location code is 11. For telehealth, it's a 95 is the location or place of service. Um, you would want to check with your insurance company. I don't have the code in front of me for seeing someone in their house or their home or outside. I don't know. I can't tell you what to do about that if you did like a walking session or something. Check with your insurance company about that. But typically, most people are going to be doing an office code or telehealth. And then I have a note here for myself. All of the insurers that I work for reimburse the same amount for telehealth and in office visits. I don't know how that is across the country and other places, but that is how it's been for me. And I don't have any sense that there will be any changes to access to telehealth. So that's a note. You also want to check with your insurer about if telehealth has to include um, video and voice. I don't know about the coverage for phone sessions, so check with your insurer about that. Um, but typically they want video and sound, voice. You'll include the CPT code. So those are the codes we mentioned before. Is it individual psychotherapy? Is it an intake, et cetera? And the number of units. So typically for psychotherapy, not typically, for psychotherapy treatment, because it is one session a day for individual therapy, you would only have one unit. Now, if you were doing a bill that included an individual session and then maybe you did a family session after, I mean, it still would be one unit for each of those services, just as a note. Um, Typically for units, you're going to be using the codes for neurobehavioral or neuropsychological testing. I also did not include psychotherapy codes, billing codes for like a crisis session. Again, different insurance companies cover that or not, and those typically are billed in units because those are often an add-on to a regular psychotherapy session. So each insurance company is specific about whether that's covered or not. So you'll want to check that with your insurance company. And then one thing I did not add here that perhaps is, of course, we send this in too, is a diagnosis. So for most of the insurance companies I work with, you need at least one diagnosis. You can send in multiple, but most insurance companies just need a primary diagnosis. In terms of diagnoses, some insurance companies do not cover like the Z or R codes. Some do. I've had them rejected and accepted. So I don't know. It depends on the insurance company as well. Maybe it depends on the code. So if you prefer not to give, if you prefer to give like a Z code as a diagnosis in your work, check with your insurance company or the insurance company of your client just to see if they'll cover it. So that's something to be aware of as well. But generally, for other treatment codes, they're covered. I haven't encountered this. What I was just thinking about eating disorder treatment or substance use disorder treatment. I don't know. Some insurance companies, at least back in the day, had rules about types of diagnoses they would cover. I haven't seen that be the case. personally. So, this is a matter of maybe there's a time that you submit a claim, it gets bounced back. They may ask you to adjust the diagnosis. You could follow up with them about why, but this is when we're talking about insurance company specific rules. These are some examples. Okay, so understanding insurance reimbursement. Again, if you're credentialed or have been, if you're going to be credentialed with multiple insurance companies, their reimbursement varies. So I don't have any insurers that are reimbursing the same amount across the board for the same codes. The big note here, and so this is a difference. Well, it's the case for me as an in-network provider. But if you're an out-of-network provider, you do not directly contract with insurance companies. It is important to know that the insurance company has an allowed amount. So for each code, they have an amount that they will reimburse either to the provider as an in-network provider, or from which they determine, how much of a session the client will get covered. So if you're an out-of-network provider and your fee is, let's say, $300 a session for 90837, then the insurance company may say, well, for our 90837, we only allow $122. That is all your client would get counted towards their deductible. And let's say that they met their deductible and the insurance is now covering some portion of the session, that would determine how much money they get back. So that's just a note. That's a lesson I learned early on. When I was out of network, I knew that my client had a deductible. I assumed that it was going down by the rate that they were paying me, but it was not. It was going down by a smaller number, which meant that they had to pay longer than I thought they would, and probably they thought they would, to meet their deductible to have anything covered. So that's some insurance math, if you will. Also, reimbursement differs by provider type. So this comes up if you have, let's say, a group that includes psychologists and master's level folks. Insurance companies have, or if you have other types of providers like a psychiatrist or a nurse practitioner, insurance companies have their payment tiers based on your license type. So this can come up, this gets confusing for some folks because let's say that you have a social worker who works for you, a licensed social worker, they have a PhD, they're still going to be reimbursed at the master's level because insurances go by license type. And at least at this time, for social workers, there's just one license, whether you have a master's degree or not. Since for psychologists, we, at least at this time, have to be a psychologist, have a PhD or doctoral degree to be licensed as a psychologist, we would get reimbursed at the doctoral level. And so the reimbursement is different, probably, I don't know, maybe about 20% or something. It depends on the insurance company. So a difference, like I said, so that's a note too, if you're going to expand to a group and you've got different levels working, you'll notice the reimbursement is different. So that's going to make a difference as you're thinking about payment for folks, for instance. So that's just a note. I guess one more note here about as an in-network provider, if my out-of-pocket fee, it doesn't matter what my out-of-pocket fee is. So the insurance is going to reimburse me what I have contracted to agree to receive from them for the various services that I'm providing. So copays versus coinsurance. Assuming that the client doesn't have a deductible, which we'll talk about here in a moment, the insurance company says, okay, this is our agreed amount, our allowed amount, and the client has to pay $15, let's say, per session. So the client pays you $15, you submit the claim. If, I'm going to do a round number here, but no, whatever. If the insurance company is going to reimburse you total $122, they will subtract the $15 and send you the remaining. So that's what you would expect to get from the insurance company. A coinsurance is a percentage of what the insurance company reimburses. So if a client has a 35% coinsurance and the insurance reimburses $122, the client owes you 35% of $122, and then the insurance company will reimburse you the rest. When you are in network with an insurance company, which means you are directly contracted with them, you have to accept that amount. You can't do balance billing, which would be saying, okay, well, my out of pocket fee is $175. The insurance company plus the copay reimburses $122. So then you owe me the difference, out of pocket client of that. You are 100% not allowed to do that. So that is a note. When you're directly contracted, you have to accept what the insurance um, contracts that they will pay you. Um, Another benefit that we saw with the Affordable Care Act is that back in the day, people used to have no deductible for medical treatment, but had a deductible for mental health treatment. Nowadays, any deductible that a client, an individual has, is applied across the board. So let's say you have an deductible, but not for going to your PCP. We fall under the same umbrella as PCPs for many plans, meaning that even though a client may have a $1,000 in-network deductible for mental health care, they might not have to pay at all. Now, if they have a deductible for medical coverage as well, they probably have to pay out of network or pay ahead of time for that. But typically, deductibles for PPO plans, at least, I can never get into that, PPO versus HMO. But for like a PPO plan, typically people just have a copay or a co-insurance. Um, so in general, is a deductible is the amount of money that people have to pay out of pocket before the insurance will reimburse. If you're an out-of-network provider, so you are not contracted directly with the insurance company, and the client has a deductible, their out-of-network deductible is likely higher than their in-network one. So if their in-network deductible is $1,000, their out-of-network deductible is probably $2,000. So they need to pay $2,000 of the allowed amount that the insurance contracts or allows to reach that deductible. So it would be $122 times however, whatever that divides into 2,000 before the insurance will then reimburse to the client or you, but typically to the client, some amount of money. The same goes if the client has an in-network deductible that has to be met before the insurance will reimburse to you as a contracted provider. They have to pay the $122. And then once they meet their deductible, and I mean, you all probably have your own insurance, your deductible is being met by going to various doctors, et cetera, et cetera. So the deductible may go down sooner based on how much the person is being seen by other medical providers. Um, Out of pocket max is a certain amount of money that the insurance will cap each year to say, maybe the person has a $2,000 deductible out of network, but once they have paid a total of $5,000, then they no longer have to pay co-pays or co-insurance. So around this time of year, people start hitting their out of pocket max. So we send in claims, and the client typically has a $15 copay, but it's coming back saying that they don't have a copay at all. They've likely met their out of pocket max. And then with timely filing, and then I'll talk about reconciliation for a moment here. With timely filing, insurance companies typically have a certain amount of time that you have to submit claims by in order to be considered to get reimbursed. So this might be important for people who maybe are procrastinators, that maybe you let your bills pile up and it's been 6 months and you decide to send in all of your billing. There are some insurance companies that will say, you missed the timely filing window, we will not cover the services. In my experience, I've had companies where it's 6 months, other companies where it's 1 year. So whatever the case is, you want to get that first bill in as soon as possible for a variety of reasons, because you want to know how much, if what the insurance company quoted you was correct, if maybe they have met their out-of-pocket max and didn't know, so we thought they had a copay, but they don't. You want to know that as soon as possible. But like I said, there are rules about how long you have to file a first claim in order to get paid. Because if you miss that timely filing window, you're just out of luck. You will not get any reimbursement from clients. And this will be an issue a risk management issue because now you've got a problem with your client because, I mean, you may be asking them to pay money, but it's really your fault. So try to make sure it's not your fault. So another note with timely filing has to do with reconciliation. Somebody, either you or maybe a billing person, as the claims are coming in, you want to confirm that one, the claim was covered, and two, that you're being reimbursed what you expected to be reimbursed, and that includes whether the client has a copay or not. Is we thought the copay was $15, it's actually 25. We thought the copay was 15, it's actually 10. You want to try to figure that out as soon as possible, especially at the beginning. But you need to do reconciliation all along the way for the reasons we sort of talked about here. They've met their deductible, they've maybe met their out of pocket max. Um, things change, especially towards the end of the year. Also, I didn't talk about this. Insurance resets for people at various times of the year. So for many people, it's January 1st. Deductibles reset. It may be a new plan, so they might have a new copay. All of that resets in January for many people. For some people, it's July. For some people, it's October. So that's something that you want to know. So you may see some changes along the way based on that. So you need to be reconciling um, all along the way. So the last piece here, as we're wrapping up and leaving time for questions, documentation, of course, is an important risk management strategy because, again, um, you want clients to know what their responsibilities are and also what yours are. So we've got the No Surprises Act, which is what is enacted a few years ago. Um, Particularly important if you're an out-of-network provider. What what do clients expect to pay each week? What does that look like monthly? For the course of treatment you're talking about, what can they be expected to pay? Letting them know that up front. I feel the same way. I mean, it applies to me too as a out of net or in-network provider. Letting them know before we even get started with therapy, I checked your benefits. This is your copay, or you've got a deductible. This is what you would need to pay each session. It would probably be about 5 sessions before you hit your deductible. After that, you either have a co-insurance or a copay. We let people know that ahead of time. Informed consent. Important things to note here: who has access to the client's information, billing information. So my practice has a biller, so she has access to like their demographic information. She uses that to submit bills. The information I send to the insurance company is, we bill for these codes. Um, this is, for most people, they just need to know what their copay is. But we also let them know, if I send out a claim and the insurance company doesn't reimburse, then you're responsible for the payment, just letting you know that. And also, we try to file our claims within the week so that we get it back hopefully within another week. So it may take a couple weeks, or maybe it takes 3 days. It just depends. But we let clients know as soon as possible. And also, like, how will we collect fees? Now, there may be an issue with continuity of care. What if a client can't pay, right? They thought they had no copay, or sometimes clients do not tell you that their insurance has lapsed, and now all of a sudden they owe money. That can take a little time for the insurance to let you know, like, hey, this person doesn't exist in our system anymore. Um, so, for continuity of care, you want to be thinking about and have some policies around and talk with clients about, do we put you on a payment plan? Or do we have to stop sessions depending on how much you owe? You want to be really clear with folks about that. Maybe have some people that you refer to, maybe a low fee clinic, but be really clear with clients about what might happen if they're not able to pay. And I think my biggest imperative here with payment is to let them know as soon as you possibly can, um, so that there aren't disruptions in care. And we can't always avoid that for any number of reasons. We try to find ways to avoid it, if you will, as much as we can. And so that's why proper planning, understanding the process is all really important. So there are some resources here that I will share that are in your notes. The trust has some guidelines and some guidance on the No Surprises Act if you've got questions about that. APA has a billing, a testing guide, billing guide. That's where I referenced the information I have, one of the places. And then health behavior assessment. We didn't talk about that. So APA has CPT codes for psychologists for that. Okay, happy to open the floor to questions folks might have.
Great. Thanks, Dr. Stanley. Yes, we've got several questions. Um, Going back to documentation and compliance, what are the documentation red flags that put clinicians most at risk for audits, would you say?
Hmm, you know, I have noticed a quite a drop off in auditing due to the Affordable Care Act. I got audited way more for not any particular reason that I was aware of. I haven't been audited in a lot of years, and I know that differs based on insurance company and such, but um, yeah, I mean, the only thing that I've heard of is any odd inconsistencies in billing might get someone noticed, but inconsistencies maybe like billing, multiple sessions with the same client in a week consistently. I mean, those are things that might stand out as um, an outlier. But I feel like I got audited maybe once a year when I first started, but prior to like since the Affordable Care Act, it has not happened as much. Well, I'm not saying it won't happen, but
Right. Not
like yeah.
great.
Mhm.
I think that was great, talking about making sure you're on top of your billing, not letting things stack up. How can practices ensure timely filing, especially for clinicians who are new to insurance-based work?
Mhm. Yeah, I mean, if it's an individual practice, you probably want to set aside a day each week to do your billing. And for my practice, and I even had this for myself, I have multiple ways of tracking who I've seen. So I'm 100% telehealth at this point. So if it's on my calendar, it happened, but also need to remind myself if a session didn't happen to make some adjustments. I keep track of when I run people's copays, but I try to do my notes and send in billing within, a reasonable amount of the week at least.
Hmm.
And then depending on how fast your insurance company reimburses, you might get that back within a week. Sometimes our insurance company is very quick and it's 3 days. So you'll kind of be learning the rhythm, I mean, your own rhythm, but I'd say have depending on how many people you see, a half a day set aside um, to make sure that you're billing and another half a day to make sure you're reconciling. Mhm.
Great. What about no-shows? How can clinicians ethically handle missed appointments if insurance does not
Mm,
reimburse for those shows? Any thoughts
yes.
on
Absolutely, yes. Glad that that was asked because I didn't cover it. So that's part of your informed consent policy, right? Letting people know that insurance companies do not reimburse for no shows. We can't bill a session that didn't happen. And so you outline your no show fee. So, do people need to give you 48 hours or 24 hours to reschedule or cancel an appointment? And what is the fee that they need to pay you if they miss that window, if they don't cancel in that amount of time? So that's also part of our informed consent. Your insurance will cover these sessions, assuming that they cover it. If you miss a session or late cancel, this is the fee.
that? Mhm.
Um, so yeah, and I think just in terms of good practice, generally you want to have a fee that's probably reasonable for your population. So if you see mostly folks who are using their insurance, and they usually have a $15 copay. I mean, obviously you can charge whatever you want, but make sure to let people know at the beginning that's something you talk with them verbally about and also including your paperwork.
Mhm.
So they're not, I mean, some people will be surprised, but so that they're not surprised.
Yeah. What about telephone calls? How do you bill those, and what are considerations about that?
Yeah, so for out of network folks, you want to have your fee schedule, if you will, available to clients as part of your informed consent agreements. For in-network folks, you will want to check and, see if the insurance covers it at all. If they, cover phone calls. If not, you want to have that as part of your fee policies. So for my insurance, for my practice, I have my non-insurance fees that we charge. Um, so that's, you want to be clear about that. I'm not sure if insurance companies tend to cover phone calls. So that's something you want to know, check with the insurance company about. And again, if you get contracted, you'll have a list of all of the cover codes,
Mhm.
but still confirm. Mhm.
You mentioned about practices that insurance companies used to do that are not consistent with mental health parity, and we're supposed to have mental health parity now. But what
Mhm.
insurance reimbursement practices are you still seeing that you think may be abuses of mental health parity?
Mm. In terms of individual practitioners, maybe? Or
No, I mean insurance
Mhm.
companies, is there anything that they're still doing in terms of, I don't know, denying bills or,
Yeah.
higher copays, or is it all, like you said, now mental health is supposed to be treated like
Yes.
primary care?
Yes. The main one I've heard of is insurance companies not wanting to pay the 90837. I haven't experienced that. Like I said, there are some insurance companies that can be a little more difficult to work with. And so that is the main thing I've seen. But since we no longer have to get for just basic outpatient treatment, we don't have to get pre-certification typically. That's been a huge. I mean, that took up so much time to have to do that for people. And I see people who have HMOs and PPOs, and it's back in the day, if you had an HMO, you certainly had to get pre-certification.
Mhm.
So it's been pretty good. I mean, I think I remember being nervous when parity happened, but it's been pretty user friendly, aside from the 90837 for some companies. Mhm.
Okay. In terms of, practice management and, your experience with a large group practice, what are some best practices for setting internal billing policies across a multi-clinician group practice?
Yeah. A few things. One, being really clear with clinicians about the time rules. So if the session is this long, this is the code we use. Yeah. And then, of course, making sure that you've got policies for when notes need to be done
Mhm.
for billing purposes for timely filing. At my practice, we've got basically a form people fill out each week that again sort of lists who they saw. So we've got multiple checks in the system to try to prevent, like, oh, I forgot that I saw this person, uh, sort of thing. And so it's a matter of like letting all the clinicians know what you know, the time expectations are, and what needs to change if you only see people for 30, saw someone for 30 minutes, needing to change the code. Um, and so, yeah, education, and then having someone, maybe a biller who's doing some extra checks in the system to make sure everything looks okay.
Mhm.
And like I said, you can do a corrected claim, resubmit a claim if there are any issues that you notice, either once it's gone out or once it's come back in. So that, yeah. Mhm.
Okay. Any thoughts about when a practice should consider outsourcing billing versus handling it internally?
Yeah. Um, yeah, I mean, if it's possible, it's nice to have an internal biller. But I think so I did the billing for the practice until it got too big. It took up, a full day and a half or so to do it. And so um, having someone who's dedicated, who can check benefits in a timely manner, who can send out billing in a timely manner, who can do the reconciliation, because that goes back to practice stability. If you're not, it's possible that a person's claims haven't been covered because they changed insurance and didn't tell you. Like, you want to check that as soon as possible. So, um, I'd say if you're going to outsource it to, let's say, a billing company, just finding a good company, trying to get a dedicated person within that company would be useful so that you're billing, you have a point person. That would be something that would be really important to me is
Hmm.
having, even if I use a billing company, having one person who's my point person who I know is going to be working on my billing primarily for continuity as well. And then unfortunately, I've heard that sometimes people still need their own internal biller because billing companies tend to get paid based on like, your billing, so a certain percentage of it, which may not be enough. What's the word I'm looking for? I mean, I guess to say bluntly, they may not care whether your billing is coming in exactly as it should because they're gonna get paid based on you know the money that you receive. So if you don't receive money, it's companies may not always be so motivated, I guess is really a word too. So that's the benefit of having an internal biller that you can put your hands on, for instance.
Yeah.
Mhm.
We did have a question from someone who was wondering if you could um, quickly state again the difference between copay and coinsurance.
Yes, a copay is a fixed amount, so $15. A coinsurance, assuming that you're going to be billing the same code, let's say you're always billing a 90837, a coinsurance is some percentage of that. So what that requires for you is understanding what the insurance company reimburses. So like I said, if it's $122 for a 90837, it would be 35% of that, for instance.
Yeah.
And so, you know, it's predictable if you are always billing the same code and you know what the insurance reimburses. If it happens that sometimes you need to bill a 30-minute session instead of a 60-minute session, the coinsurance changes. It's 35% of, let's say, $50. So yeah, copay is a fixed amount. And, you know, so thinking between like a 90837, or I'm sorry, a 90791, which is the intake, that's going to be different. So the coinsurance on that would be different. The copay on that would be exactly the same, $15, for instance.
Got it. Thanks.
Mhm.
And then if a client, in terms of the duration, if a client arrives late or leaves early, is the expectation to recode the session to what it actually was in real time?
I think so. That is my understanding. So that's something you need to talk with clients about because maybe you've got some room in your schedule to extend it a little bit, but on a 60-minute appointment, you've got 53 minutes to play with. So you may decide that you need to reschedule the client if they come 15 or 20 minutes late if you don't have time, or you recode it to a 45-minute. That's the insurance company's expectation, is what I will say.
Hmm.
Mm-hmm.
Um, I don't know if you can easily go back to your list of codes. We're almost out
Yes.
of time. Um, there were some questions about these. Just one interesting one I thought. The 90785 interactive complexity. What about using that interactive complexity to support a longer session if the client is emotionally complex, tearful, or agitated?
Yeah, those fall under the category of I would check with your insurance company to, well, one, I would want to understand what that means because I mean I think a lot of clients can be complex,
Hmm.
but two, just to see if the insurance company actually covers it.
Right.
And would they? There was a question earlier about what might get flagged.
Hmm.
If you're using a complexity code with all of your clients or with the same client, I mean, I don't know for sure, but the insurance company might have questions about that because they're thinking about like, what are people generally doing, in a population? What are therapists typically billing for? And so anything that's a little bit out of the ordinary is more likely to be flagged, especially if it happens
Oh,
regularly.
right.
Mm-hmm.